Hello everyone, welcome back to another case. A 40-year-old male comes into the ER with complaints of blurred vision and on palpating the abdomen cries ouch. He is taking deep fast breaths, making full use of his lungs and is also sweating from his forehead. He seems confused at first. It has been just 2 minutes since his arrival and he asks to go to the washroom. You ask him to wait, but he can't wait. Also, his relative has brought a bottle of water with him. He says he feels thirsty a lot. The relative also reveals that he vomited before coming here, and when you are examining him, you smell a fruity smell. You list all symptoms as follows: fever, altered mental status, blurred vision, nausea and vomiting, also sweating, tachypnea with deep respiration, abdominal pain and tenderness, then polyuria and polydipsia. Also, the man tells you that he has lost weight since the last couple of days and seems fatigued. Judging from these signs and symptoms, this seems to be a case of diabetic ketoacidosis. Patients typically have a history of type 1 diabetes mellitus and rarely type 2 diabetes mellitus, which we call as ketosis prone diabetes mellitus. A physical examination will reveal tachycardia with hypotension, as can be estimated from the sweating, then dry mucous membranes with sunken eyes, small respiration, fruity breath, altered mental status, and fever if the person has an infection. Let's discuss the pathogenesis. The basic disturbance is that insulin levels are decreased and glucagon levels increased, which leads to increased hepatic gluconeogenesis and decreased glucose uptake by the tissues, ultimately leading to hyperglycemia. In the adipose cell, triglycerides are converted into free fatty acids catalyzed by insulin sensitive lipase. Insulin inhibits this enzyme, so when insulin levels are decreased, free fatty acids are produced in great numbers and they are converted into ketoacids in the liver via beta oxidation, thus leading to ketoacidosis, which then brings about a decrease in the bicarbonate serum levels, and then there is metabolic acidosis, which in brain causes altered mental status. Also, keto acids are converted into acetone, which gives rise to the fruity smell. The Kussmaul respiration is a compensatory mechanism in response to metabolic acidosis. What exactly precipitates diabetic ketoacidosis? Most commonly, it is the non-compliance of the patient. He or she forgets to take a dose, or it can also be due to an infection where he or she will present with fever, like our patient. Acute coronary syndrome is a less commonly seen cause. We have three parameters to confirm the diagnosis. Glucose levels should be more than 250 milligram per deciliter. Then ketosis should be evident. Then metabolic acidosis with a pH of less than 7.3 should be present. Now let's move on to treatment goals. First, we have to restore the fluid loss due to polyuria. Then we will correct the hyperglycemia, the acidosis and the electrolyte disturbances. Last of all, we will monitor and manage any complication of diabetic ketoacidosis. So, we will first administer 500 to 1000 ml of normal saline per hour and replace the entire volume 24 to 36 hours. Then, we will administer insulin as IV bolus in adults to control the hyperglycemia. Then, we will replace the potassium. Why? Because insulin causes potassium to shift inside the cells, thus leading to hypokalemia. Please note that potassium should only be administered if it is less than 5.2 milliequivalent per liter. Bicarbonate and phosphate replacement is unnecessary and not required. Moreover, bicarbonate can cause hypokalemia and cerebral edema in children. Guidelines also recommend that when the patient can accept orally, we should shift to subcutaneous insulin. Let's have a recap. Tachypnea with deep respiration, which is known as Kushmal breathing. Then type 1 diabetes mellitus will be the history, along with dry mucous membranes can be seen in questions. Then moving on to the pathogenesis, the entire pathway should be known, it is quite high yield. Then hyperglycemia and ketoacidosis and metabolic acidosis are the primary reasons we can diagnose diabetes. Then moving on to the precipitating factors, non-compliance is the biggest reason, followed by infection. The diagnostic criteria should be kept in mind. Then for the first point of treatment, which is restore the circulatory volume, should be always kept in mind. Then the volume should be replaced in 24 to 36 hours. Then insulin causes intracellular shift of potassium. Bicarbonate replacement is unnecessary and not required, moreover because it causes hypokalemia and cerebral edema. That will be all. Thank you so much.